Crazy. There's so much wrong with this case. Hey, I'm Dr. Jeff Yu, a board-certified ER doctor in the USA and Canada, and it's 6 p.m. in the Pitt, and I'm going to be watching the Pitt Season 2, Episode 12. I'll go over what's realistic, what's not, and I'll explain all the medical management throughout the show. Let's get to it.
You all right?
Okay. Let's see.
Oh, shit.
How did you get a bloody nose?
He slipped.
So they're starting the episode by coming to the patient that had Emma in a chokehold. Violence in healthcare is incredibly common, and I shared my own personal experience with this just about a month or two ago when a patient stabbed one of the nurses in the face with a pen, and I had to take this patient down. He was actually critically ill, and I had to intubate this patient for the safety of him and for the safety of the healthcare workers. But I've actually been attacked on the job a couple of times throughout my career as well. So this is definitely something that is very, very common.
What exactly happened?
He grabbed him. He threw her up against the wall. I ran in and gave him a shot.
Right, and did he slip before or after the shot?
Before.
He had me in a headlock. I didn't see what happened.
What did you give him?
4 milligrams of first aid.
Who wrote the order?
I had it in my pocket. I was on my way to waste it, but she was sideways.
There is a lot going on in this conversation between Dr. Robbie and Nurse Dana. It's kind of frustrating the way that Dr. Robbie is handling this. He's actually accusing Nurse Dana of inappropriately giving medications to this patient, when in reality, if a patient is assaulting a nurse or a healthcare worker, if the physician is not present, it actually is quite common for nurses to chemically sedate a patient, at least where I work. I would never fault a nurse for giving the patient a high dose of midazolam for someone that's agitated and combative. For Dr. Robbie to pit himself against Nurse Dana because she did something that was totally appropriate for the safety of the healthcare workers I just don't think that's very realistic. If a doctor did this in real life, nurses would quickly start to hate working with that doctor and start to see that doctor as not valuing the safety of the overall team.
This department is clearly too much for one person to handle. It's not healthy for you or the patients, and I'm very concerned by what I've witnessed today with some of the staff. What is going on with Langdon and Santos? I saw them having it out like it was fight night.
Santos is responsible for revealing Langdon's benzo addiction. This ED is the best of the best, and I would put it up against any emergency department in the country, and it is going to be yours to f up, so don't f
Langdon.
up.
And so I think as the shift goes on, Dr. Robbie's psyche is just slowly unraveling. And you can see him getting more and more short with his colleagues, with the residents, with patients as well. All the different stressors that happen inside the emergency department kind of do weigh on your conscience. Your mental bandwidth slowly deteriorates, and you do have a tendency to, have a shorter fuse and a bit more short or curt. I feel like it's very exaggerated the way that Dr. Robbie is kind of like lashing out at the people around him. He just seems like he's becoming more and more of a massive dick in this department.
I need help. I gotta go. I can't breathe.
Damn.
Trying jaw thrust.
Drive-in with severe respiratory
Left
distress.
side dialysis shunt, probable renal failure and fluid overload.
When was his last dialysis?
It was supposed to be yesterday morning.
They're saying that he is hemodialysis dependent. He's probably coming in with heart failure, and they want to start him on BiPAP, but the guy is actively vomiting, and BiPAP is a clear contraindication. That's not typically what we would do, and typically in order to diagnose congestive heart failure, we would need a lot more investigations. Like, we need to first see if he has pitting edema or swelling to the legs. We'd have to listen to the lungs to see if there's crackles. We typically shoot an x-ray to see if there's cardiomegaly or an enlarged heart cardiac silhouette, and pulmonary edema, which shows like fluid inside the lungs. For them to be able to diagnose it just quickly like that off of the story while this guy's vomiting is very unrealistic.
I'm fine.
He was choking you.
He had me by the head mostly.
You're a patient now. Full examine South 18. In case she also needs to make a statement to the police.
Is that really necessary?
Yeah.
Yeah.
Absolutely.
That guy's serious injury with force inflicted from a sedative. You are not licensed to prescribe.
Anyone else uses force to stop an assault, they're a hero, but a nurse does it and we're punished.
Jeez, this overall interaction is super frustrating. I know why the screenwriters wrote this in, because I think that the overall narrative and reality for nurses is that nurses are blamed if something bad happens to a patient, a lot of doctors will try to avoid getting blame on themselves and kind of push the blame to other people. In this situation, especially when a patient is agitated, combative, and aggressive to a healthcare worker, it is completely reasonable for a nurse to administer a midazolam, like a sedative, to chemically sedate the patient for everyone's safety. So for Dr. Robbie to keep harping on this issue and to be like arguing back and forth with Nurse Dana about the situation is absolutely bullshit. I'd be so pissed if I saw one of my colleagues doing something like this.
BiPAP starting at 10/5.
Good hard squeeze, good lung sliding, but there's a ton of B lines.
Pulmonary edema.
B lines on an ultrasound show pulmonary edema or like a lot of fluid in the lungs. So I think what they're trying to show is that he has flash pulmonary edema where he has like pink frothing from the lungs. This is kind of what it looks like. The way that they're showing it makes it look like he's like vomiting this up, whereas in reality, people with flash pulmonary edema would be kind of like in a tripoding position where they're leaning forward, breathing like this, and constantly coughing with like kind of bubbling type froth coming from the mouth. It wouldn't be like a fluid like they showed when the guy rolled up in the truck.
Which is best treated by what, Dr. Giovanni?
Nitro.
Nitrates.
In flash pulmonary edema, we do the opposite.
What he really needs is dialysis to get the fluid off.
Flash pulmonary edema, congestive heart failure. Let's talk about this. This is something that we deal with almost every single day in the emergency departments. Most oftentimes it's not as dramatic as this, where the guy is like has pink froth coming from the lungs, but we do see that occasionally. The management for flash pulmonary edema or congestive heart failure is best memorized by a mnemonic called LMNOP-BD. So L is Lasix. Essentially, it's a medication that helps to pee out some of the fluids, but in someone in renal failure, you wouldn't be able to do that. So you would have to use something like dialysis to get that fluid off. M is morphine to kind of like decrease the cardiac strain. N is nitroglycerin, which is a medication that dilates all the vessels around your body to kind of lower the overall blood pressure and decreases the amount of strain and effort that the heart has to push against when it's pumping each time. O is oxygen. You support their lungs by giving them supplemental oxygen, whether it's through nasal prongs, a face mask, or the BiPAP mask. And P is positioning. Like we wouldn't lay someone in flash pulmonary edema down flat like this. You would want them sitting upright so that all of the fluid actually settles down to the bottom of their lungs with gravity. If you lie them down flat like the way that they lay him down in the show, the oxygen saturations would go down and his respiratory distress would actually get a lot worse. B is BiPAP, like the mask, which increases the amount of pressure inside the lungs and essentially pushes out the fluid from the alveoli. And D is hemodialysis, and that's to essentially just take out as much of the fluid from the overall system to decrease that fluid from flooding the lungs.
Do you have any medical problems, Frida? High blood pressure, low thyroid, AFib.
So, what happened? Well, she walked into the car.
Okay, so this elderly lady was knocked down to the ground from a car at low speed. She has a history of AFib, which is short for atrial fibrillation. And with that, most people are on an anticoagulant medication, like a blood thinner, to prevent them from having strokes. If someone is on a blood thinner and they get knocked down to the ground, we get really concerned that they might have a bleed inside of their... In these cases, typically what we would do, apart from like worrying about a hip fracture, which she may have after she was knocked down to the ground onto her left hip, we would send her for a stat CT scan of her head and go from there. Sometimes we need to also reverse the anticoagulant medication if there's a strong suspicion of blunt head trauma with a bleed.
Do you take aspirin or any blood thinners?
Eliquis for my AFib?
Yeah, so the blood thinner for the
here?
atrial fibrillation.
No, not really.
Here?
Oh yeah, that hurts.
All right, 4 of morphine and Zofran.
Morphine is one of the most common pain medications, and we usually combine that with an anti-nausea medication like Zofran, which is ondansetron, or Gravol, which is another anti-nausea medication, because the opioids can often cause people to become very nauseated and vomit, especially if they've never had those medications before.
I was wondering if I could do a quick examination of you.
Oh, no, I'm fine. I was in the car.
Would you mind taking your shoes off?
could use a pedicure.
I suspect what they're alluding to is either diabetic or hypertensive peripheral neuropathy. So sometimes if you have uncontrolled diabetes or uncontrolled high blood pressure, especially in elderly patients, this can actually decrease the sensation to your nerves going down to your hands and your feet, what we call a glove and stocking pattern of numbness and tingling. And this can often alter people's balance and can also alter I guess their sensation of like pressing on a gas pedal or a brake pedal. Romberg testing we often combine with also pronator drift. What we get people to do is you get them to stand up, feet together, and hold their hands out like they're holding a tray, close their eyes, and keep their balance. And essentially what we're testing is their sensation of the pressure and proprioception throughout their body to see if they're able to maintain their balance.
Hemoglobin's only 9.2.
He's anemic from renal failure, like medieval bloodletting.
Essentially, and that is something you should step out for, Mason. Casey, thank you.
Got a good vein for 16.
One donor back, 500 cc's, no more.
Please don't tell me they're gonna bloodlet this guy.
Okay, let it
It's
out.
crazy. Okay, what they're saying is that because the guy is so fluid overloaded, they're actually going to just bloodlet the patient, essentially insert an IV and just let all the blood drip into a bucket or drip onto the floor to get some of the fluid out of his system. This is so not realistic. You know, there's one condition called polycythemia rubra where you have way too much production of red blood cells, and that's one instance when sometimes we'll bloodlet patients to get some of the blood out of their system. But for someone that's in flash pulmonary edema who's volume overloaded because they have renal failure, we would never bloodlet them. We would just call nephrology to come down to the ER with a hemodialysis machine and start dialyzing them right away.
If it's all right with you, I'd rather stay.
Damn.
I'm not a quitter.
Okay, but something
Strong
for
girl.
you. But stick close to Donnie for the rest of the day, would you?
Awesome.
We're here to help, not to be punching bags.
Hell yeah. Awesome that Nurse Dana was willing to send Emma home. One of the things that we have to worry about for Emma is that she'll have PTSD going forward. So it's going to be really important for Nurse Dana to debrief with Emma after the shift is completely over, and to also arrange for a formal debrief with all the staff members that's witnessed that attack on Emma so that they can kind of like debrief about that situation with a formal trauma counselor. In that situation I was telling you about earlier where one of my nursing colleagues was stabbed with a pen by that patient, we debriefed as a team in the nursing office while I was on shift, and it meant that the wait times actually went way higher, but I just thought it was really important to actually bring all the staff members into a separate quiet area where we could actually talk about what happened. I mean, it wasn't super long, but we actually organized a formal debrief with a formal trauma counselor. I think it was like 3 or 4 days later, and everyone that was involved, including the security guards and the support workers, nursing staff. I was the only doctor there, but everyone was there, and we were able to kind of say our piece of like what happened, some of the emotions that we experienced afterwards. And I thought that was incredibly cathartic to just be able to air our frustrations and talk about the emotional roller coaster of what it was like to be attacked like that while we're on the job. I also feel like all of us walked away from that trauma counseling session with a strong sense of solidarity. Like we all walked away with a strong sense that we were there to support each other after an attack like that.
Sit tight.
This place sucks.
Tell me about it. Try working here.
Man, Santos's bedside manner is just getting worse and worse as the shift goes on. Crazy.
Blunt trauma from a fireworks explosion in his storage unit. The blast launched him into a rolled-down garage door frame.
In blast injuries, there's 4 different mechanisms that we really care about. They go primary, secondary, tertiary, and quaternary. So primary blast injuries are from the actual shock wave from the blast itself, from the explosive hitting the body. Secondary blast injuries are from debris that fly towards the person and hit them. Tertiary blast injuries are from the body actually being launched by the blast itself and, you know, hitting things like the door or the ground. And then quaternary blast injuries are all the environmental factors that happen afterwards. So whether that's the fire or fumes or smoke inhalation in that area. Any one of these mechanisms could actually cause lethal injuries, which is why we care so much about the 4 different types.
Can you hear me?
Yeah. Dante, a lot of ringing.
He's got ringing in his ears and decreased hearing. That would definitely raise suspicion for tympanic membrane rupture, which is one of the primary blast injuries that you can get.
especially with organs that are air-filled. How are we looking, Dr. Santos?
There we go.
Fast negative.
That's the primary blast injury that I was telling you about. Damn.
Langdon.
Me.
What is this?
It's a pretty big flap.
Saturalia?
It is indeed.
I've seen injuries like this many times throughout my career, like machete injuries to the head, people falling and hitting their head against like sharp objects. When you have a big scalp laceration like that, sometimes you can get a flap and it exposes the galea, which is kind of connective tissue, which kind of, it almost kind of looks like saran wrap. It's like the smooth connective tissue that overlies the skull. And if you get a subgaleal bleed, those can bleed like crazy. Sometimes the galea actually needs to be primarily repaired with sutures before you actually close the scalp laceration. Oh, just like that.
Okay, we got a couple arterials that need control.
Potassium's high, 6.5.
Be expecting with the missed dialysis.
Needs insulin and glucose to shift the potassium intracellular.
Is at risk for arrhythmias.
No peaked T waves, no QRS widening. Insulin puts him at risk for hypoglycemia.
There's so much wrong with this case. I'm getting a little bit frustrated with this case. Phlebotomy and bloodletting a patient with flash pulmonary edema and congestive heart failure is not something that any developed country, a hospital would actually do for a patient. It's just not realistic at all. I don't know why they did this. I don't know, seriously, I just don't know why they decided to bloodlet this patient. Okay, I'm gonna look past that. The next thing that they're saying is the patient has hyperkalemia, which means that the potassium levels are very high. This is something that we very commonly see in patients that have missed their dialysis runs. There are a few different ways for us to solve the issue of high potassium. And first of all, it's really important that we solve the high potassium levels very quickly because that can actually cause life-threatening irregular heart rhythms that can cause a patient to go into cardiac arrest, especially a potassium of 6.5. A patient's gonna be, that is a life-threatening level of potassium. So the first thing that we would do is give calcium gluconate. Calcium will help to stabilize the cardiac membranes and decrease the likelihood that you will go into irregular cardiac rhythm. The next stage in the management for high potassium levels is to shift the potassium intracellularly. The first way is by giving a combination of insulin and dextrose or glucose in through the veins. Second is giving salbutamol, which is essentially puffers that we often give for asthma, but it also works to push the potassium into the cells. And the third one is giving sodium bicarbonate. Typically, we wouldn't choose between one of the three. With someone that has a potassium of 6.5, we would give all three in combination with each other while we wait for the last management, which is to actually get the potassium out of the system. And the best way to do that is doing hemodialysis. And that's another reason why they should have actually called nephrology to come down to the emergency department to dialyze the patient in the ED instead of bloodletting him. They are touching on a lot of different real aspects that we do in the emergency department, but the way that they're going about it is not actually medically accurate.
Is that the mom of the heat stroke?
Yeah.
Do you believe it was just an accident?
Does it matter?
As I mentioned in the last video, when you become a parent, your perspectives completely shift. You have these idealized views of what you will do before you become a parent. I would never give my kids screen time. I would never let them watch TV. I would never let them do this or that. I would do this or that. And when you become a parent, reality kind of has a way of slapping you in the face and helping you to understand why so many parents do the things that they do. One of the realities of being a parent is, I don't know, I do think that every parent has this weird thing inside of them where they just look at other parents and be like, oh,
Langdon.
like, what the hell are you doing? And like, you're very judgmental to other parents, you know? I think if every parent could just take a moment and realize that parenting is really, really hard and there's no clear one right way, no clear guideline of the best possible way to raise a child, given, you know, everyone's different circumstances, people could just be a lot more understanding and generous towards each other.
Hello,
Oh
Miss
my God.
Stevens.
It's a bad sunburn.
Your last patient left her blanket.
Oh, she died. The cancer mom with 2 kids. I don't even remember the last time I cried.
Pretty good at shutting down our feelings.
They are touching on such a real aspect of working in the ER. It is so crazy, the shit that we see every single day, the stories that we hear. it is not normal. It's not normal to see people dying. It's not normal to see people having life-threatening overdoses over and over again. It's just like all of this crazy shit. You really do have to guard yourself emotionally so that you're not like having emotional breakdowns throughout every single one of your shifts. That can be a really tricky thing when you're early in your career, to understand how to like guard yourself when you're on shift and how to be an empathetic and compassionate person on shift and when you leave the ER, and be able to relate to the people around you. And I think this is probably one of the aspects that leads to a lot of burnout and compassion fatigue among healthcare workers. And I think if you haven't developed proper coping strategies, either when you're going through your training as a resident or in your early career, the chances of you having longevity in the career are quite low. Like, you just won't last in this line of work if you are not able to process all of the trauma that you see and make sense of it all.
What if you fall? What if you have a heart attack or a stroke and there's no one there to help you?
You worry too much.
How can I not? Look what happened today.
So a couple points on this case. So hip fractures, first of all, are a really serious injury because they most often occur among elderly people that are quite deconditioned. One thing that I often advocate on social media is for people who are in their 40s, 50s, and 60s to regularly engage in resistance exercises. If you do not actually put in the work to maintain that strength and balance, you're going to be more likely to fall down to the ground and break a hip. And if you break a hip, your chances of dying within 1 year are about 20 to 30% in that first year afterwards. Also, your chances of returning to your previous functional baseline are only in the range of 25% as well.
Galia, sub-Q, skin staples.
For the actual scalp flap, the most common way that we would repair that is just with a staple gun. Click, 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 click. Nice. Yeah, so that is realistic. They're using the staple gun.
Oops.
I always tell medical students the one word that they're never allowed to say in front of a patient is oops or uh-oh. So, this is a mistake that she made, but it's not a major issue. Typically what we would do is we would just simply remove that staple and redo it.
We never say oops in front of a patient.
Yeah. Oh, that's exactly what I just said.
More Fati.
More like memento mori.
I have no idea what they're saying, but if you know, maybe let us know in the comments.
I can't believe Pine Ridge closed. When did that happen?
ER's closing is a major issue, not only in America because of Medicare cuts, but it also happens where I live in British Columbia. So in more rural communities, it's harder to get doctors to actually travel to those communities to work in the ERs and to staff them. When these ERs close down, it means that all the people in those communities who have serious medical issues don't have direct access to medical care, and so they have to travel longer distances to access care. And this obviously introduces a major issue of people dying or having worsening outcomes because inequality of access.
I choked her? No, I would never do something like that.
Your lab results were positive for alcohol and cocaine. And it can lead to confusion, paranoia, aggression, and even psychosis.
Yeah, so this so much parallels that attack that I experienced on the job a couple of months ago. Because my patient was critically ill, when I actually questioned him, he said that he had no recollection of stabbing my nursing colleague in the face with that pen. And for me, I felt like there was a lot of like internal turmoil when I was giving my statement to the police, because I had to tell the police that the patient wasn't conscious and it wasn't a true intentional attack on my nursing colleague. And it felt a little bit wrong for me to give that statement, because when someone harms a coworker of yours, you kind of want justice. You want people to be held accountable, but at the same time, I couldn't lie in my police statement and tell them that this person was fully conscious of what they were doing, So because my patient had no true criminal intent of stabbing my nursing colleague, he wasn't held liable. And I think in this scenario, he also won't be held liable against attacking Emma. Which is one of the big frustrations that healthcare workers feel, is that there's no direct consequence to them in the long run. Whereas like the healthcare workers have to endure not only the direct trauma, but the PTSD that comes with it, as well as the burnout.
What's going on?
Fucking chest hurts. Systolic's down to 78. Okay,
pericardial
560 bolus,
tamponade,
100%
yeah.
non-rebreather, please.
So he's got pericardial
infusion,
tamponade.
RV collapses, tamponade.
Yeah, let's prep for pericardiocentesis.
He has collection of blood around the heart that's actually increasing the pressures around the heart, preventing it from filling and actually perfusing the rest of his body. You have to perform what we call pericardiocentesis, where you use an ultrasound to guide a needle into that sac to drain it out.
Have you ever done an apical approach?
Nope.
We talked briefly about different approaches to doing the pericardiocentesis. The old method was doing a subcostal or a subxiphoid approach, where you start from underneath the rib and point up towards the patient's left shoulder. That was kind of like a blind technique before we had very easy access to ultrasounds. A lot of the times you would actually be doing that blind, where you're just like sticking the needle and kind of like hoping to hit the right space and drain the blood. Now that we have ultrasound readily available, the more common approaches are either a parasternal approach, where you go directly beside the breastbone or the sternum, or you do an apical approach, where you approach from the area of the left nipple and point up towards the opposite right shoulder. You would put the probe down and you would visualize the needle on the ultrasound and kind of guide it into that space where the blood has collected to drain it out. This is pretty realistic the way that they're depicting it. They're also depicting inserting an actual catheter to make sure that it continues draining blood out of there, which is actually what we do in real life.
You ever gonna tell me what really happened in there?
I did exactly what I needed to. Now there's a young nurse who gets to go home in one piece because of me. This place is always teetering on the brink of disaster, with or without you.
Damn. Go Nurse Data. Holy crap. That was a really powerful dialogue. Kudos to Nurse Dana for standing up to Dr. Robbie, because I think she hit on so many important points. Dr. Robbie needs to get his shit sorted out. He just seems like he's not able to really manage his own emotions or decompress or reflect on all the shit that we see on the job here. So, crazy.
We have a case manager that will put together a robust plan that I think will make everyone happy.
You know, every old person knows what it is to be young, but no young person can know what it is to be old.
Good case. I'm super glad that they're covering this. Yeah, it's so well placed. I'm so glad that they covered it, because it touches on elderly independence, it touches on polypharmacy, it touches on compassion and also understanding as well. I love how they said, you know, every elderly person knows what it's like to be young, but not every young person knows what it's like to be old. That's very true.
How much longer until I get these things off and go home?
You assaulted a nurse.
Yeah. You said it was the cocoethyl thing that made me go crazy.
Well, if you're drunk and you kill someone, you still kill someone. After we clear you in a few hours, you're going to take a ride with the uniformed officer outside who's going to take you in for processing.
No. This cannot be happening. This whole place and
Langdon.
all of you!
Langdon.
It's a little bit unclear whether he was actually aware of what he was doing or not. McKay is totally right. He assaulted a nurse. The nurse suffered injury, may suffer PTSD down the line, so he should be held accountable for that and should be assessed in court. If not court, he should at least be seen by a psychiatrist for like psychosis or antisocial personality traits. Like, these are all things that need to be considered. He can't just feel like he's entitled to walk out of the hospital and live his merry life after he's done something like that.
Hey, so this is it, huh?
Yeah.
I had a lot of friends who liked to see how close the edge was. Trouble is, they all inevitably found it.
Yeah, it's crazy that out of all the different residents, attendings, and staff members, it's McKay that's actually the one that's addressing the elephant in the room. Yeah. And that's the one that's cutting through to him as well.
You leaving?
Yeah, my shift is over.
Put in the extra time if we need it.
You know, 62% of ED docs report suffering from burnout.
The statistic of 62% of ER doctors suffering from burnout is absolutely correct. One of the issues with setting clear boundaries is we sign up for this job to heal the sick, to save lives. It's just hard for us to say, oh, time's up, we're out of here, and then leave all of these loose ends with not knowing what's going to happen with our patients. I don't know what the right answer is for the issue of burnout and physician wellness, but if you have any ideas, drop it in the comments.
Unwitnessed fall from the warehouse catwalk where he works as a security guard. Oh my God. Orlando.
Oh, no.
He left 5 hours ago.
All right, so that's it for season 2, episode 12. If you found this enjoyable, subscribe to the channel, give it a like, and drop a comment, and I'll see you in the next one. All right.